Welcome to our comprehensive guide on hand joint mobilization. In this video, we'll explore the anatomy, movements, and therapeutic techniques used to improve mobility and reduce pain in the hand joints. Whether you're a student, therapist, or simply curious about hand function, this journey will help you understand the essential principles behind joint mobilization. We'll start by setting the stage with patient and therapist positioning, then move through each joint, from the thumb to the interphalangeal joints. By the end, you'll have a clear grasp of both the theoretical and practical aspects of hand joint care. Let's begin our exploration of the intricate world of hand joints and their mobilization techniques. Proper positioning is the foundation of effective hand joint mobilization. The patient is usually seated or in a long sitting position with the wrist placed at the end of the couch or table. The forearm is kept in a mid-prone position for optimal access. The therapist stands beside the patient, facing the wrist, ensuring both comfort and control. The therapist's left hand stabilizes the distal ulna and radius, while the right hand grasps the patient's hand or metacarpal region. This setup allows for precise manipulation and minimizes discomfort. Establishing this positioning is crucial before proceeding to any mobilization technique, as it ensures safety and effectiveness throughout the session. Let's focus on the thumb, specifically the first carpometacarpal joint. This joint is a synovial, saddle-type joint, allowing a wide range of movements. The articular surfaces include the trapezium and the proximal part of the first metacarpal, both concavo-convex in shape. Several ligaments, such as the capsular, dorsal, palmar, and lateral ligaments, provide stability. The thumb's unique structure enables flexion, extension, abduction, adduction, and opposition. Understanding these anatomical features is essential for applying the correct mobilization techniques and appreciating the thumb's remarkable versatility in hand function. The thumb's movements are powered by a group of specialized muscles. Flexion is achieved by the flexor pollicis longus and brevis, as well as the opponens pollicis. Extension involves the extensor pollicis longus and brevis, along with the abductor pollicis longus and brevis. Abduction and adduction are controlled by the abductor and adductor pollicis muscles, respectively. Opposition, a unique thumb movement, is primarily handled by the opponens pollicis brevis. Recognizing these muscle actions helps in both assessment and targeted rehabilitation, ensuring that each movement is supported and restored effectively. Arthrokinematics describes the small, precise movements between joint surfaces during motion. For the thumb's carpometacarpal joint, flexion is accompanied by ulnar gliding, while extension involves radial gliding. Abduction results in dorsal gliding, and adduction leads to ventral gliding. These subtle glides are essential for smooth, pain-free thumb motion. Understanding arthrokinematics allows therapists to apply mobilization techniques that mimic or enhance these natural joint movements, promoting better function and reducing discomfort in patients with thumb joint issues. The thumb joint has specific positions that are important for both assessment and treatment. The starting and resting positions are midway between flexion extension and abduction adduction, providing a neutral baseline. The close-packed position, where the joint is most stable, occurs during abduction and extension, with abduction being more restricted. Recognizing these positions helps therapists determine the joint's health and select the appropriate mobilization technique. Additionally, understanding the capsular pattern where movement is most restricted guides targeted interventions for optimal recovery. Distraction techniques are used to increase joint play and reduce pain in the 1 to 5 carpometacarpal joints. The patient sits with their hand placed on a table for support. The therapist fixes the carpal bones with one hand, while the other hand pulls the metacarpal distally from the carpal bones. This technique helps improve range of motion and alleviates discomfort around these joints. Distraction is often the first step before applying more specific gliding techniques, ensuring the joint is prepared for further mobilization. Dorsal and ventral gliding techniques target the 1 to 5 carpometacarpal joints to enhance flexion and extension. The therapist stabilizes the carpal bones and glides the metacarpals either dorsally or ventrally, depending on the desired movement. Dorsal gliding increases flexion, while ventral gliding promotes extension. These techniques not only improve joint play, but also help reduce pain and restore functional hand movements. Consistent application of these glides can make a significant difference in hand mobility and comfort. The intermetacarpal joints, located between the metacarpal bones, also benefit from mobilization. Dorsal and ventral gliding techniques are used to increase joint play and reduce pain. The therapist fixes the adjacent mid-shaft of one metacarpal and glides the other in the desired direction. This approach is especially useful for restoring hand flexibility and function, particularly after injury or prolonged immobilization. Mobilizing these small joints can have a big impact on overall hand dexterity. The Metacarpophalangeal (MCP) joints are synovial, condyloid joints connecting the metacarpals to the proximal phalanges. These joints allow flexion, extension, abduction, and adduction, powered by various muscles such as the lumbricals, flexor digitorum, and interossae. Ligaments like the palmar and collateral ligaments provide stability. Understanding the structure and movements of MCP joints is crucial for effective mobilization, as these joints play a central role in gripping and manipulating objects. To mobilize the MCP joints, distraction, dorsal, ventral, medial, and lateral gliding techniques are used. Distraction increases joint play and reduces pain, while dorsal gliding enhances extension and ventral gliding promotes flexion. Medial and lateral gliding target adduction and abduction, respectively. The therapist stabilizes the metacarpal and manipulates the proximal phalanx in the desired direction. These techniques are essential for restoring full range of motion and function, especially after injury or in conditions like arthritis. The Interphalangeal IP joints, including both proximal and distal, are hinge-type synovial joints. Flexion and extension are the primary movements, supported by collateral and palmar ligaments. To mobilize these joints, distraction and gliding techniques are applied. The therapist stabilizes the proximal phalanx and manipulates the distal phalanx in the desired direction. These methods help increase range of motion, reduce pain, and restore fine motor skills, which are vital for everyday hand functions. In summary, hand joint mobilization is a vital skill for improving mobility, reducing pain, and restoring function. We've covered the anatomy, movements, and specific techniques for each joint, from the thumb to the interphalangeal joints. Remember, proper positioning, stabilization, and understanding of joint mechanics are key to effective mobilization. Always tailor your approach to the patient's needs and progress gradually. With practice, these techniques can make a significant difference in hand health and quality of life. Thank you for joining us on this journey. Keep practicing and keep learning.